Thank you, folks. I'll be brief because I'm sure that you want to listen to the panel, but I am pleased to have a part in today's work because I'm very proud of my association with the Shared Care Committee and the work that they do. So my role today is to introduce the Partners in Care session to you guys, and this will highlight a lot of the Partners in Care projects that we're doing across BC. The shared care initiatives consist of many joint efforts by family physicians and specialist physicians in regions across the province. In fact, there are approximately 1,500 GPs and 125 specialists involved in this work currently. So it does attract a large number of individuals. They're specifically working on streamlining referral and consultation processes, shared care planning and re-referral criteria, diagnostic standards and communications, telephone advice and protocols, and very, very much more. And I do see a lot of this work that they're doing as being very core work to the progression of our integrated primary and community care initiatives across the province of BC. It is a true partnership. So I'm very pleased today to introduce to you Leslie Rogers, who's a shared care project coordinator for Fraser Northwest Division, who will moderate this session for us. Thank you, Leslie.
Thank you, Carol. You know, we could have filled this stage with people eager to talk about the accomplishments of Partners in Care in their divisions, but obviously we couldn't all do presentations. So what's all the excitement about? It's because Partners in Care attracts people who are passionate about healthcare, who are committed to the hard work that collaboration requires, who know that it can be frustrating and time-consuming, but that it's worth it because we can accomplish so much more together than we ever could alone. The whole absolutely is bigger than the sum of its parts. To give you just a flavor of the creative ways Partners in Care is flourishing around the province, we've selected 3 distinct examples. At the same time, we're finding that no matter where we are, we face similar challenges. So first, we're going to have an overview of Partners in Care, what we've learned collectively in the divisions so far. And speaking of passion for this work, we have Deanne Neufeld. She was the coordinator for the South Okanagan Similkameen Shared Care Project for the past year, and has only just turned over the reins to Tracy St. Clair. Welcome to Partners in Care, Tracy. Deanne studied clinical social work at the University of Regina and obtained her master's degree in human services leadership from the University of Calgary. Prior to her position as shared care coordinator, she worked in healthcare for 16 years as a mental health therapist and has coordinated numerous collaborative initiatives and pilot projects between healthcare, the ministry, persons with developmental disabilities, and mental health. Deanne moved to the Okanagan a year and a half ago and says she's loving the lifestyle and natural surroundings. Well, she moved from Calgary. Deanne.
Thanks so much, Leslie. I still don't understand why everybody doesn't live in the Okanagan, but I guess maybe I'm a little biased. So those of you in the audience that actually know me know that it's really hard for me not to talk a lot. And so I've made some really rigid notes, and so I'm going to do my very, very best to stick with them. I like to go off on tangents and tell stories. So I'm going to try and monitor myself to make sure that I get through the introduction for Partners in Care. So Partners in Care creates the opportunity to bring family physicians and specialist physicians together to facilitate the building of relationships between them and to encourage collaboration, communication, and satisfaction in the delivery of healthcare for co-managed patients. We are in the business of relationship building, system redesign, and practice enhancement, working to improve processes, increase satisfaction for physicians, and where patients have access to the services they require by the right person at the right time, creating a seamless flow of care and information. Partners in Care was initially initiated following the express need being heard in the field that improved linkages between family physicians and specialist physicians was a priority. This needs assessment illustrated that communication was poor between family docs and specialists, as well as between other caregivers, that relationships were poor and sometimes territorial, and we have heard that in other speakers today, that patients were falling through gaps, and that duplication was happening with regards to investigations and consultations, and that patients perhaps were not cared for in the most efficient place. For example, physicians taking on more of the role of primary care versus the patient, seeing the patient specifically for their specialties. Partners in Care allows for pockets of the population around the province to identify their own specific needs and to develop tools and processes to address them through the use of the PDSA cycles. These separate locations bring local GPs and specialists together to brainstorm what is working and what is not working, and then build new processes, models, templates, tools, and care plans, and to create a model of sustainability, including partnering with the health authorities and other stakeholders to spread and sustain system change. At PIC, we have a common goal of streamlining the patient journey as they receive care between their general practitioner and their specialist. The key players that we need to involve as PIC coordinators are patients, and in the South Okanagan, we partner with Patient Voices Network, and you already saw our patient, one of our patient reps, Harriet, that was up here. She has also been quite involved in our project. We also need to bring together, of course, the GPs, the specialists, the Health Authority Administration, the Shared Care Committee, divisions of family practice, community stakeholders, as well as has also been mentioned, IT folks, perhaps like the EMR vendors. Operationalizing depends on the location and what they have identified as their priorities. Each community works collaboratively to determine the most effective way to meet their needs and goals. They may develop a steering committee, an advisory committee, separate working groups, and establish physician champions. Clay had mentioned this earlier, so I won't stay on this too long, but the triple aim from the IHI is the attended outcome throughout the province for shared care, but the actual programs that are developed in each region will be different. So here is a map of all of the projects for shared care around the province. The stars represent the Partners in Care sites. The challenges associated with this work is that it is harder to implement than one would really think. It's a slow process, as has been mentioned, and sometimes it feels like a train having difficulty coming out of the station. I sort of visualize that old steam engine kind of chugging and having difficulty getting moving. Sometimes we have people that are jumping on the platform, and sometimes we have some people that are just kind of running to get on, and others that are thinking, maybe. Here is also a representation of the Partners in Care sites and what initiatives they are working on. So you can see we are a very, very busy bunch of people. Assembling a group of people with the same interests for a meeting and asking them to collaborate and to work and to find workable solutions doesn't just happen in an organic way. We at Shared Care, Partners in Care, provide the facilitation and the leadership. But we need participants who see the value and champion our initiatives, such as like early adopters, so to speak, that can spread and be passionate about our work. We also have one of our physician champions here, Dr. Brian Forsley, is our specialist champion. He has been integral in moving this forward. So Brian, it would be great if you'd just give a little wave, because people might want to seek you out and talk to you about your role here. He's been great. We are in the business of changing cultures and systems. This is not so much a barrier, but it does tend to slow things down. The work is slow by nature, and in a true collaboration, each voice and opinion has value and must be taken seriously and honored. As mentioned earlier, sometimes there are territory issues and ownership issues amongst our stakeholders. Sometimes we find participants come forward with priorities that are really near and dear to their hearts and may have difficulty looking at that bigger picture. However, this is workable, and with the PIC's facilitation skills, our diplomacy, and our expertise, we can and do move these initiatives forward. One of the other challenges that we think about is change saturation. When we think about all of those projects that we saw in the different stars, there's a lot of things going on, and we have to be really cognizant that people can only take so much change at one time. If we want to make sure that it's solid and it sticks, we have to allow that time and process. So for regions like mine in South Okanagan that are kind of less urban, there are serious issues of travel and geography that must be considered. So for some others, it has been mentioned that health authorities may present a challenge for engagement. For the PIC coordinators, there is also a challenge for disseminating throughout all our different initiatives as we are working across the province. And we are working at better communication to share what we were doing in each location. Today's event is a great example of that, and it's wonderful to be able to meet people that I've only talked to on the phone. We have been successful at PIC at getting our work done through successful engagements of physicians, MOAs, stakeholders, and champions. We also bring patients to that table and their families' voice as well. Remuneration for the physicians that we bring forward to help us with our project has also been key. Support from the Shared Care Committee, and that's not only financial support, but that's support in regards to concepts and processes, as well as the fact that the Shared Care Committee allows each region to forge ahead and identify their own goals and what they would like to work on really also moves to enhance our success. I'm sticking really good to my notes, you guys. I've just got one piece left. So our lessons learned. In regards to engagements, I know my piece is one-on-one engagement with the physicians out in our rural communities is essential. I find the more that I can have FaceTime with physicians, with MOAs, with patients, with stakeholders, the more success I have. So really building those relationships is key. That's actually a favorite of mine as well. We need to make sure that when we engage, we are engaging the right stakeholders for the right issues and bringing the people at the table that have a voice. There was a doctor talking about what's happening with the GPs not being in the hospitals. So he would be someone I would want on one of my committees so that he could talk about that and we could brainstorm and find local solutions to that kind of a problem. So when we brainstorm, we really need to make sure that everybody at that table has a voice, and we do have patients at our tables, to make sure that the project or direction chosen is the right one for that community. So equal voice, patient, family, GP, specialists, MOAs, community, patients. Harriet and I actually did a presentation together at the Patient Quality and Safety Forum, and that was great fun for both of us. I think it was a great project. We have to remember as well in lessons learned that changing cultures and doing system change is a process that takes time. It takes patience, perseverance, and of course passion, as mentioned. It also takes dedication, but I am telling you, when it comes together, it is fantastic. It's just that great rush of adrenaline. I don't know if any of you are runners, but you know when you get that runner's high? Same thing. It's awesome. One of our big lessons is being able to share our learnings province-wide, so we're not recreating the wheel, and we need to decrease the isolation of our shared care coordinators. Support from the Shared Care Committee is essential. And my last point, oh, there's my lessons learned. Okay, so my last point was actually brought up by a patient in the previous one, Val LeBlanc, who said something, and my paraphrase is about true collaboration. So true collaboration is that everyone has a voice, and you come to brainstorm and make those solutions a collaborative effort. Thank you.
Thanks so much for that terrific overview, Deanne, for your contributions to Partners in Care, and good luck in your new ventures. We'll miss you.
Thank you.
So let's look more closely now at some examples of the amazing collaborations going on around the province. Providence Health Care, Partners in Care, is acclaimed for its rapid access to consultative experience. The acronym is RACE. Plus, there's a lot more going on at Providence, as you'll hear. To tell us about RACE and other initiatives at Providence Health Care is Margot Wilson. Margot is the Director of the Chronic Disease Management Strategy at Providence Health Care and the lead for the Partners in Care work. She holds a Master's of Science in Nursing from the University of British Columbia. In 2011, Margaret was awarded the College of Registered Nurses of BC Award of Distinction in Nursing. And also in 2011, she accepted on behalf of the Shared Care team the Health Employers Association of BC Golden Apple Top Innovation Affiliate Award and the IPAC Deloitte Public Sector Leadership Bronze Award for RACE, Rapid Access to Consultative Experience. Congratulations to Margot and Providence Partners in Care. Margot.
Thank you very much for the opportunity to come and talk with you today about the work that we're doing at Providence Health Care. And I'll just, there we go. So our Partners in Care journey at Providence Health Care started in April of 2010 in collaboration with the Shared Care Committee and Vancouver Coastal Health. And we really had the intent to improve care for patients who had complex chronic conditions. Now, we've heard a lot about the context already this morning, and I won't go over that again. But prior to starting this work, we did do a needs assessment with our stakeholder groups, including the specialists, family physicians, and patients. And it came through loud and clear to us that there really was a need for improved communication, improved access to specialists, and improved collaboration and relationships between all of the groups. So we've done a fair amount of different areas, and I will, as Leslie said, be talking about one of the main areas that we've worked on. But we've worked on telephone advice, referral acknowledgement. Bob mentioned some of the work that we've been doing when he was talking, and also around shared care planning and compacts. We've now started on the inpatient community interface, looking at family physician identification, notification, and involvement in the care when patients are in the hospital. But today I will be talking about rapid access to consultation expertise. And I just want to start off with a story about a patient which really illustrates some of the gaps in care and what we can do for those. So Robert is a 65-year-old man. He lives in Vancouver. He has a history of diabetes type 2 as well as heart failure. And he likes to go walking. He walks every day, and he starts to notice that he's feeling increasingly short of breath when he's out for his walks. So he sees his GP. His GP refers him to a cardiologist, and he waits several months to get in to see the cardiologist. When he does get to the cardiologist adjusts his cardiac medications, and he does note that Robert's blood sugar is really running on the high side. So he adjusts his glucose medication as well. So Robert continues on with his life. He's taking his medication. He's continuing on his daily walks. And his shortness of breath is great, but he's starting to feel kind of lightheaded and actually does fall down one day and injure himself on his walk. So when he's out speaking with his family doctor, the family doctor is surprised to see that the glucose medication had been adjusted because she intentionally had been keeping it on the high side because she knows that he gets lightheaded. She was also surprised to see that Robert had been referred to another endocrinologist because he'd already been seeing an endocrinologist in the community. So this story, it just sort of illustrates some of the gaps in care. Robert, he waits too long to see the specialist. There's lack of clarity around the care provider role. There's recommendations are made not with taking into consideration the entire plan of care. Specialists are taking on some of the primary care roles. And there is a cost to the patient and the healthcare system based on Robert's experience. So I will come back to his story at the end. But for now, I'm going to talk about rapid access to consultative expertise, and it's an innovative model of shared care, otherwise known as the Raceline. And the objective of this really is to provide real-time telephone advice to avoid unnecessary emergency department referrals or unnecessary face-to-face consults. And it started in June 2010. We started with 5 specialty areas. It's one telephone number that family physicians can call. They hear a message that gives them a selection of specialty services, and they press the corresponding number and are routed directly through to the specialist's cell phone or pager for just-in-time advice. So we have done an evaluation on all of our shared care work. These comments here really pertain to the RACE line, and the evaluation is all done through the lens of the Triple Aim framework, which looks simultaneously at population health, the care experience, and the cost per capita. So RACE has been viewed by family physicians as an excellent resource that they would like to see expanded. There's high user satisfaction, that all would use it again, and 83% on the survey responded that they believed it helped manage care for their patients. So just some of the more specific results. We've had over 2,500 calls to the Raceline, and that was from June 2010 to June 2012. We know from the information that we receive back from specialists that 3/4 of the calls are answered within 10 minutes. Over 90% of the calls are less than 15 minutes in length, so it's a fairly rapid response rate. The length of the telephone calls is not that long. And based on about 450 calls, we know that in 60% of those cases, face-to-face consult with a specialist was avoided, and in 37% of the cases, an emergency department visit was avoided. So looking at those last two metrics, doing a bit of a cost analysis exercise, we were able to determine that there's up to about a $200 savings per call, depending on the specialty area that's been called. Whoops, sorry. Just going to go back there. And so based on those metrics there, we do believe that there is improved patient and provider experience, improved efficiencies in emergency department flow, cost savings, and really increased specialist capacity, because now they can see the patients, or they have the ability to see the patients that they really do need to see. So some of our key learnings around RACE, well, we know that involving the patient voice right from the beginning in any kind of healthcare redesign is absolutely completely important, and we have Val LeBlanc and Delia Cooper, who are here today, who have been part of our team right from the beginning, and having their voice at the table has been so important. We also know that one size does not fit all, and what fits for an urban Vancouver area is likely not what is going to fit for other areas. So the things that are developed, they need to be tweaked, and they need to fit the needs of that particular area. We have taken great care with the Raceline to avoid replacing any of well-established and communication networks that are out there and working. And RACE is meant to fill a gap, not to interfere with any communication lines that are already there that are working well. We do have criteria for specialists who participate, and the specialists know that they need to be accessible and answer the call in a timely manner. They need to be prepared to have a collegial interaction with their family physician colleagues. And the discussion needs to have an educational component, because it is meant to increase the knowledge capacity of the family physician. There are some limited resources involved in the Raceline, and that's mainly around coordination of the schedules, rerouting the numbers, some administrative support. There's also the TELUS telephone line, which is about, with a couple telephone trees, is about $80 a month. And then there's the medical services plan fee code for both specialists and family physicians. Specialists can bill $60 per call, and family physicians $40 per call. We have been spreading the RACE innovation, and we have found that collaboration really is key to successful spread. Our physician co-leads, Bob Levy and Gary Mazawita, have traveled around the province, working with the different communities, assessing what their needs may be. And we've developed RACE in a Box, which is a document that really gives you the information that you need to start up a Raceline. It comes with a decision support tree with some key questions that helps you to determine what type of model would best fit those needs. And currently there are 3 services that are trialing a provincial service, and that really makes sense to have a provincial service when there are not that many specialists in the particular area, or maybe when they're all centered in southwestern BC. So just to take us back to Robert's story, without the RACE model, he really was experiencing issues around accessibility, role clarity, communication. And with the RACE model, his issue could be addressed in the family physician office in collaboration with the specialist input. His medication could have been adjusted on that day, and a face-to-face consultation could have been avoided. So just in summary, taking us back to the Triple Aim framework, RACE has the potential to enhance the care experience. And sorry, that's just way too little down there for me. I can't see that. So by providing knowledge transfer for family physicians, improving the specialist family physician interface through improved communications, simplifying the patient journey. They may not have to wait a long time to see a specialist or travel large distances to see them. Population health might be improved as access to care is improved, and the per capita cost of healthcare is at least controlled through the avoided consults and emergency department visits. So just to end off here, I'd like to share some feedback from a family physician who emailed this to me, and in particular, the last couple of lines there, where this family physician says that it gives me a level of professional satisfaction, professional empowerment, and improved patient care. And this is what the RACE model can do for family physicians in the community. And I'm going to pass back to Leslie at this point.
Margot, thanks so much for packing in such delicious information into a short period of time. So its vast geography is but one of the challenges Northern BC faces in providing physician services to its residents. But Northern Partners in Care, centered in Prince George, is finding made-in-the-region solutions to address these challenges. Here to share the North's unique but also more broadly applicable experiences is Dr. Dan Horvat. Dr. Horvat is a family physician in Prince George, an assistant professor with the Department of Family Practice UBC, and co-lead for Northern Partners in Care. He has a long-standing interest in understanding how systems improve. A portion of his academic time is spent gaining an increased understanding of how the most effective healthcare systems function and how their approaches to success could be applied in the Northern Partners in Care context. Dr. Horvat also has extensive experience with divisions of family practice and the Attachment Initiative. He is currently contributing to the Faculty of Medicine's MD Undergraduate Curriculum Initiative and is a member of the BCMA board. Plus, he has kids, 2 boys and 1 girl, and he says he spends most of his spare time, wherever that comes, shifting kids between various sporting venues. And he loves snowboarding when there's time. Dr. Horvat.
Thanks, Leslie. And thanks, Margot and Bob Levy and Clay and others for being the crazy dancers up there to kind of initiate this stuff so that other people could kind of follow. I thought that was a really, really good video and an interesting analogy because it's interesting kind of work and definitely requires courage and support. So I'm glad that we and others can kind of get in and kind of follow behind, and we've learned a lot from those who have gone before us, so thank you very much. This kind of gives a bit of a sense of the geography that we're dealing with in the north, about 300,000 people that reside in northern BC, about 2/3 of the province. There's issues of population density, a lot of small communities, geographical and climate challenges. Not only is it a long distance for people to come in to see specialists, but at times the roads are pretty hazardous. So there's all kinds of geographical challenges that limit the access to care. And so we're trying to set out to see what we can do to mitigate that. But as we do the work, it becomes increasingly clear that as we improve kind of access to care for patients in remote communities, that really a lot of the same sorts of ideas apply in larger centers as well. Whether you're a long distance away or close, often the care and the support that you need isn't necessarily there. And certainly as GPs, being able to access that support when you need it can be a challenge. So it does seem to apply across different settings. And it does seem that the patients are okay with remote care. That was mentioned earlier, I think, by somebody, maybe it was Kelly, talking about dermatology, and how in that experience people have found that, yes, being on Salt Spring Island and getting help is fine. They don't necessarily need to travel. And certainly we found that there's situations where people are traveling 2 and 3 times many hours for, as somebody commented earlier, a 10-minute visit, or they need to get an x-ray and then they have to go back later, or a CT scan, they have to go back later. It's crazy what we put people through sometimes, and it's really, it's great to be working with both GPs and specialists that see that something could and should be done to deal with that differently. So, I think there's advantages to patients, to GPs, having that access, that support. It's great to work with specialists that want to provide that level of support. I think, as mentioned by the fellow from Richmond, having that support increases the capacity of primary care, increases the capability, and that helps patients get continuity of care and comprehensive care in a single place instead of having to go to many places. And what we're finding is that specialists want to leverage their expertise. They really don't. They feel at times a bit embarrassed by what they put patients through to get their services, and they really want to leverage their expertise. And it's great to see that, there's not only shared care, but specialist services, GP services, ministry, BCMA, and others kind of behind, a lot of health authority involvement behind actually finding ways to leverage that support and expertise. We all know that the system isn't designed to do the kind of things that we need to do, and it takes redesigning to make it happen. So our approach has been basically to support improved physician services for residents in northern BC by improving shared care between GPs and specialists. We have definitely taken the approach that we're about empowering and supporting people who want to do something different. So we didn't create an initiative so much as invite people to come to the table with ideas of their own that we could find a way to support. And there were certain criteria for that. We wanted to have not only a specialist interested, but a GP, and ideally a GP from a relatively urban community like Prince George, but also from some of the smaller communities as well. We've taken a collaborative approach from the beginning of working with GPs and specialists in a collaborative fashion, but also with the Health Authority. We've had BC Cancer Agency involved with some of the initiatives, and had discussions with people from Children's and Provincial Renal Agency as well. Right now there's approximately 40 GPs that are kind of directly involved in one way or another, and 25 specialists. And we're looking at basically improving collaborative care relationships across kind of jurisdictions, and also improving care pathways, and that was brought up earlier as well. Really, how do you actually provide the right care at the right time? How do we create those pathways to make it happen? So we've ended up with many specialists and many GPs interested in this work, and so this is kind of a matrix, and if you look across the top of it, it talks about COPD, CHF, emergency room support, gastroenterology, geriatric services, mental health, oncology, nephrology, and we've also got a RACE program. So again, thanks to Margot and others and RACE in a Box, and it's been very, very helpful, their support. We've also just recently kind of added HIV into the mix because there's been a well-developed program through one of the specialists and the Health Authority around HIV, and there's increasing interest by particularly that specialist and some people within the Health Authority and working closely with shared care. So we're able to take the learnings that they've had through their work and apply them to the work that we're doing. Along the left-hand side there is the different things that we're finding can actually improve the care pathways. So things like being able to access somebody by phone, being able to access somebody by email, using video conferencing in certain circumstances, having visiting clinics, specialists go out to some of the communities, being able to understand how to do referrals more effectively, understanding role clarity. So in some communities, we may have a fair amount of expertise, we may have a general internist, so we don't necessarily need the same level of support for some communities than others. What does a GP do? What does a specialist do? What does the non-physicians do? And so some of the projects are kind of bumping up against that and trying to work through those issues. What is the role of continuing medical education? If we're extending information out to individuals through continuing medical education, we have a fairly well-developed system to do that. How do we maximize the utilization of that so that people can access the care when they need it? They don't just go to a talk, a lecture, and hopefully remember to apply that in practice. And also there's credits that come along with CME, and people appreciate that. And we're in the process of developing an electronic shared care plan so we can share information between providers in an electronic environment. And that's sort of at the, basically almost at the trialing stage. It's been developed, and we're going to be trialing how that works so that multiple providers can actually not step on each other's toes, but collaborate in the care of patients more effectively. We're also working with Northern Health and Interior Health on secure messaging. So how do we actually send information back and forth securely? So if we're communicating by email, that we can feel confident that that information is secure. And of course the fees that have been developed by both GPSC and Specialist Service Committee have been really, really helpful, because if people have to sort of invest their time and energy in providing different types of care and aren't supported to do it, there's only a limited amount of that will occur, and I don't think we can expect people to invest a lot of their time and energy if they're not being supported for it. We've got, as I mentioned, a lot of different projects, and I'm not going to go into each one of them. There's not time to do it. The Northern RACE program has been really interesting to get up and running, and again, we've really appreciated the support. It looks like we will probably be branching out beyond cardiology, which is where we started, to palliative care, nephrology, and nephrology probably fairly soon. And it's interesting because on the palliative care side, there's a well-developed provincial program, and one of the palliative care docs said, well, we're doing this in palliative care, and we basically said, okay, if we've got a 1-800 number for the north, can we just then link it with your number? sounds like it might work. We're going to explore that. So it's really building connections and not building redundancy. The gastroenterology project is about providing email support between gastroenterologists and GPs and communities. So I'm just going to kind of not go into this in too much detail because I don't have a lot of time here. But I just want to sort of end by saying that this is a great opportunity to create kind of infrastructure and processes that kind of work, not just for one health concern, but really understand how, by developing approaches to using these technologies and these ways of communicating, that we can apply it across a range of different health concerns. And that this is a wonderful opportunity for physicians to be able to work with others and articulate their needs more clearly about what they can do differently and better. IT is a huge part of it, but certainly isn't all of it. And just to thank everybody that's kind of supported this work, particularly Shared Care, but also GPSC, Specialist Service Committee, Medical Association, Ministry, Health Authorities, and the different people that have kind of gone out there and danced before us. Thank you.
Thanks so much for that, Dan. I know it would be so interesting to hear more and more about it, but you'll hopefully take advantage of the opportunity while Dan's here to talk to him during some of the breaks. So let's move from the north, where one of the leading events yesterday was evidently a moose charging a police cruiser and causing some damage to the constable's shoulder, to more temperate climates in the Okanagan, where it might be more likely to see a deer browsing on apples in an orchard. But the Central Okanagan Partners in Care is also doing some really interesting work. And that it's not only contributing to local improvements, but to our combined learning around throughout Partners in Care. And Tristan Smith is going to give us a taster of Central Okanagan's work. He's the executive director for the Central Okanagan Division of Family Practice. He's worked for General Practice Services Committee supported initiatives since 2007, and that includes the Practice Support Program. Prior to working with GPSC programs, he worked for 10 years as a clinical dietitian at Kelowna General Hospital and Penticton Regional, with a focus on surgical wards, gastroenterology, and intensive care. He lives in Kelowna with his wife and 2 children and enjoys skiing, golfing, and playing squash. And he says that in his spare time, he's just working on his master's degree through Royal Roads University. Tristan.
Thank you, and good morning. Many thanks to the Shared Care Committee and Clay for their support over the past few years, and also to Margot and Leslie and others for arranging this part of our day today. Through strategic planning through our division in 2010, we identified patient care gaps in a variety of areas, and some of those included specialty services. And as a result of that, over the past few years, we've initiated 3 Partners in Care projects, focusing on diagnostic imaging, mental health, and gastroenterology. And I'd like to briefly share with you the journey through some of these initiatives. Firstly, our diagnostic imaging project. This project started with a meeting between 2 of our board members, myself, and the head of radiology. And during this meeting, it was agreed that there was an access problem with diagnostic imaging. Yet it took considerable time in the conversation to identify areas of concern and, for the radiologists and the radiology department. At first, it seemed like these department heads were used to people coming to them and stating their problems and expecting solutions. But as our division's leads pursued through the conversation areas of improvement for radiology, it became clear that there was a partnership. And as this conversation evolves, I think collaboration in this instance was born. Also critical was the energetic and uncompromising support from the IH, Interior Health Diagnostic Senior Administration, and their local managers, who immediately recognized that this partnership had benefits to patients and their department. And I think it's also important to note that we did have patients as partners representatives on this working group. Finally, thanks to the Shared Care Committee who provided us funds that allowed us to not do this off the side of our desks and hired skilled support staff, including Dave Harry and Penny Lane, who did a fantastic job. So the issues for us were that all patients who were coming to the radiology department were marked as urgent. Patients accessing diagnostic imaging through the ER. Family physicians were seeing their patients and saying, just go to the ER if you need this. Family doctors had difficulty reaching the department if they needed to in a timely manner. And radiologists had difficulty triaging and managing their wait lists. Triaging patients and managing their wait list. So we put in some solutions, and that was a direct phone line for family doctors to get a hold of radiologists for emergent cases. We expanded the urgency categories within the requisition form from 1 to 4 to better help triage these patients. We provided GPs with a list of wait lists and timeframes for each of the sub-areas within radiology department, and we continue to do that through our newsletter. We provided CME with one of our events for guideline care, to review guideline care. And we also have, importantly, a feedback mechanism where if there are some major concerns from the radiology department with these requests, that we can get that feedback to our members. So the results, we reduced the contact time to get a hold of the radiologist from the family practice office from 15 minutes to about 1 to 2 minutes. We reduced urgent wait times from approximately 4 to 6 weeks to, when appropriate, 48 hours. Physician satisfaction rose from 5.8 out of 10 to 9.6 out of 10 when dealing with diagnostic imaging. And we reduced diagnostic access through ER. In fact, we eliminated it through this project. We just don't have ongoing data to support that. We completely eliminated that issue. So that moves us to our mental health initiative. And this conversation started with the generous offering from the Canadian Mental Health Association to our division's leads to join their national event in Kelowna, and where we learned about other models of care, including the St. Paul's model. And this stimulated discussion at our local level. And as per the video this morning, if the St. Paul's Psychiatry Group were the leader, or the lone nuts, as per se, we were the followers. We were fortunate to involve psychiatrists and health authority members with this discussion, and it became clear there's a passion for supporting family practice and primary care through the lens of mental health. That being said, it was quickly apparent to us that this was much more complex than the diagnostic imaging project that we had. The psychiatrists didn't function as a cohesive group, and they worked in and out of public and private centers. But luckily, we have a lead psychiatrist for our steering committee who is able to bridge gaps in this case. And over the course of this year, we've identified more clearly the care gap in our area and have started to work on quick access to psychiatry assessments from family doctors' offices. We've called that the one-pack, or the one-time psychiatric assessment consult. That started this week. And it started with 2 psychiatric assessments per week for our beta test group, and is poised to grow to 9 depending on demand and availability. That psychiatrist is also supported by a mental health nurse who is able to link patients with community resources through this program, and also we're asking that they link back to the family doctor to make sure that they got what they needed, their patients got what they needed, and that they were clear on any assessments and recommendations. So needless to say, we're quite happy and excited about this work and the progress over the next few months. Finally, I'd like to share with you our experience with gastroenterology. And in our area, we have an estimated 5,000 people waiting and wanting to have this device used on them by a gastroenterologist, by a GI doc, of course. Maybe there's a few that wouldn't mind otherwise. In April, a division approached the gastroenterology group, who agreed to work with us and the health authority to improve system issues related to gastroenterology. And after discussions, it became apparent that there were a lot of people on a wait list that weren't being addressed. And specifically, there was a review of this wait list 2 years ago where they did streamline the process, but they forgot to take care of the backlog. And so new patients are coming in and being streamlined while potentially 5,000 people are waiting for a service. So our group felt that this was a priority and this was unacceptable. And we're moving forward with this as a top priority for our work. So we're collecting the data. We're just in the process right now of collecting the data specifically on who these patients are and more importantly to who the referring family physician was so we can get back and start a process. We've also revised the referral form for gastroenterology so that the gastroenterologists have more information and clear information to better prioritize the patients as they come through their system. As you can imagine, they are very busy people as well. So that's our gastroenterology project in a nutshell. To conclude, success factors that we've experienced include identifying meaningful issues and patient care gaps. We're talking about patients a lot today, and I think that's important, that we narrow in on the issues that are affecting patients and then build the collaboration around that. We found it useful to take the time necessary to develop relationships and trust amongst the stakeholders, and through that also more clarity around the aims and goals and directives of the project. We found it essential to establish good working relationship with the health authority staff, specifically at the patient care level and local manager level, but also including senior administration. And we keep the trip lane in focus while looking for win-win-win solutions for scenarios for our stakeholders. And finally, we found it useful to have dedicated staff for these projects and not to do it off the side of our desks. And that's my time. Thank you.
Thank you so much for that, Tristan. Isn't this really interesting stuff that's going on around the province? And there's a lot more. I'd encourage all of you to check in with the Divisions BC website sometime. Easy to remember, divisionsbc.ca, where you can click on to divisions, all of the divisions that are actively working on or working toward partners in care, and find out what's going on and make those connections that all of our speakers are talking about being so important.